Good morning, everyone. I'm Kristen Edmondson, and it's my pleasure this morning to introduce our speaker, Kelly Gwathmey, who's going to be talking to us today about CIDP diagnosis and management. Dr. Gwathmey is an associate professor of neurology at Virginia Commonwealth University, or VCU, in Richmond, Virginia. She, way back in undergrad, studied neuroscience and behavioral biology at Emory, and then went on to attend Eastern Virginia Medical School in Norfolk. After residency, she did both her neurology and clinical neurophysiology training at the University of Virginia, and then also completed a neuromuscular fellowship at both Brigham and Women's Hospital and Mass General Hospital in Boston. After fellowship, she went back to the University of Virginia, where she started the multidisciplinary MDA clinic there and also worked co-directing the ALS clinic, as well as working as the fellowship director for both the neuromuscular and the clinical neurophysiology fellowships. So certainly doing plenty there. And then in 2019, she transitioned from UVA to VCU, where she currently serves as the neuromuscular division chair, the neuromuscular medicine program director, as well as the EMG lab director. Currently in her clinical practice, she sees a wide spectrum of neuromuscular patients, as well as performs electrodiagnostic studies. And I just have to say, overall, she is just a fantastic physician, colleague, and mentor. We're really lucky to have her here today, and I'm really looking forward to hearing more about CIDP diagnosis and management. Dr. Gwathmey, thank you so much.
Thank you so much for having me, Dr. Edmondson, and for that absolutely lovely introduction. I really appreciate it. I'm just going to pull my slides up here really quickly. It's an honor to be here. Thank you. All right. And here we go. So we have updates in CIDP, diagnosis and management. These are pictures of Virginia Commonwealth University. It's a beautiful place in Richmond, Virginia. Please come visit us sometime. My disclosures, which were also, I think there's a link in the chat, are all related to myasthenia gravis therapeutics, speaking and consulting honoraria from Alexion and Argenx, and then consulting honoraria from Amgen and UCB. So our objectives for the next hour or so are to be able to, after you attend this presentation, to be able to describe the typical and atypical presentations of CIDP. I would like for you to be able to describe the standard evaluation of patients suspected to have CIDP, and then understand that there is an updated EAN PNS 2021 CIDP diagnostic criteria that we're all using, and then start to understand the treatment approach that we use in CIDP. And so this is our outline for the next hour: introduction, presentation of CIDP and experience, and then we'll go through evaluation, diagnostic criteria, and finish up with treatment approach. So CIDP, even though we think of it as probably one of the most common chronic inflammatory neuropathies, it's still rare, right? So the prevalence ranges dramatically depending on what studies you look at, from 0.8 to 8.9 per 100,000. And there was a more recent meta-analysis that put it about 2.8 per 100,000. And the incidence ranges also all over the place, from 0.2 to 1.6 per 100,000. And in that same meta-analysis, put it right at 0.33 per 100,000. So we think there are just over 400,000 individuals with CIDP worldwide. And interestingly, it appears to be a little bit more common in men, which is interesting because it's autoimmune, and more common with advancing age, with the peak actually in the 70s. So CIDP can occur in children. We won't be talking about that today, but it is much more common as we get older and in men. So I like to think about CIDP under a much broader umbrella of chronic acquired demyelinating polyneuropathies. So we have the CIDP and its variants, which will be the focus today. We will also be touching on autoimmune nodopathies, which we used to consider seropositive CIDP, but it's now considered its own standalone category of disorders. And then there's anti-MAG neuropathy, which we'll briefly touch on. There is demyelinating neuropathy associated with POEMS syndrome, which is polyneuropathy, organomegaly, endocrinopathy, monoclonal gammopathy, and skin changes. And then there's multifocal motor neuropathy, which we will not be touching on today, really. It'll be mentioned twice, I think. So This is a beautiful figure from a publication in 2022, which is referenced at the bottom of the screen, that really shows you how we're thinking about the classification of CIDP today. And so you'll see right in the center of this figure, there is CIDP, of which almost half of it's typical CIDP. And then sprinkled outside of typical CIDP are the variants, and we'll go through those in some detail. There's a form of CIDP, which is acute onset, that shares some similarities with Guillain-Barré syndrome, which is, of course, separate from CIDP. We do have our hematological malignancies and monoclonal gammopathies that can be associated with neuropathies, or occasionally monoclonal gammopathies are associated with CIDP. And then, as I mentioned, autoimmunopathies have moved out on their own, and they're over here standing right next to CIDP. And then also what's moved out from under the CIDP umbrella as of 2021 with that update in the diagnostic criteria is CISP, or chronic immune sensory polyradiculopathy, which we'll touch on as well. So the pathophysiology of CIDP is extremely complicated and not well understood. And there are a lot of different things going on in this figure that was published in Neurotherapeutics in 2022. But just to highlight a few things, basically the blood-nerve barrier becomes increasingly permeable, and you get these activated T cells passing through the blood-nerve barrier. And then there is some activation of pro-inflammatory cytokines as well. Having this sort of leaky blood-nerve barrier also allows for macrophages and antibodies to cross, as well as components of the complement system. And what ends up happening is you get these macrophages binding to complement deposited on these complement receptors and FC receptors on the nerve, resulting in segmental demyelination. So a lot of different things happen that result in that demyelination of the peripheral nerves. So again, heterogeneous pathogenic mechanisms. CIDP may have damage to both the distal and the proximal nerves where the blood-nerve barrier is more deficient. And as I mentioned, this is mediated by antibodies and humoral factors as well as complement to some extent. Now, the interesting thing that we're just starting to understand, and it really goes beyond the scope of today's talk though, is that different types of CIDP likely have different pathophysiologies. So multifocal CIDP, we think that there's more of a T cell and macrophage attack on focal portions of the nerve, whereas distal CIDP and sensory CIDP have much more broader heterogeneous pathomechanisms, just as an example. So to go into the presentations, I always like to start with a case. This is a 52-year-old man who moved up from Texas because he was doing poorly at home, and he moved up here to be closer to his sister who could help take care of him. And he actually came over to me through my rapid access ALS clinic for concerns of ALS due to his profound weakness. So the story goes, he moved in late 2022, and in the beginning of 2022, he developed progressive tingling, first in his legs and weakness that impacted his legs, and then it spread up to his arms over time. He went from walking normally to using a cane, then a walker and a wheelchair. And prior to this, like, he worked in construction, was completely strong without any problems whatsoever. Now, he reported absolutely no issues with double vision, difficulty swallowing, speech, or respiratory concerns, but he did lose 40 pounds, and that might have been partially because he had difficulty preparing meals for himself. So what are the salient clinical features in this case? He had progressive weakness, positive sensory symptoms, and lack of bulbar symptoms. So, probably not ALS with the sensory symptoms and the lack of bulbar symptoms so far. So on his exam, his cranial nerves were completely normal. He did have very marked diffuse atrophy of all of his muscles, and his tone was decreased. His reflexes were completely absent. And then on manual motor testing, you'll see he was about 4+ out of 5 with shoulder abduction. Around the elbows, he was 5. Distally in the hands, about a 4 out of 5. Hip flexion, 3 out of 5. Knee flexion extension in the 4+ range. 3s in dorsiflexion and plantar flexion were 4. And this was very, very symmetrically the case, as I demonstrated here. And on sensory exam, he had diminished vibratory sensation in his fingers as well as his toes. So he has CIDP, and we'll come back to him in a little bit. So CIDP does have various clinical courses and presentations, and I always refer to it as sort of the peripheral nervous system equivalent to multiple sclerosis. It can relapse, it can remit, it can be chronically progressive. You can have a monophasic course of CIDP, but by definition, you should go from symptom onset to nadir greater than 8 weeks. Okay, so these symptoms progress over weeks to many months. And so, as I mentioned a few slides ago, there is a rapidly progressive acute form of CIDP that mimics Guillain-Barré syndrome in about 13 to 18% of patients. And so that's really important for us to always keep in the back of our mind, especially if a Guillain-Barré patient has subsequent relapses over many months, right? So in contrast to Guillain-Barré syndrome, when these acute CIDP patients come into the hospital, it would be unusual for sure for them to have respiratory failure or cranial nerve involvement. And then autonomic dysfunction, which we see so commonly in Guillain-Barré syndrome, is not typically a feature of acute onset CIDP. Again, so if I like to organize this in my head, I have our typical CIDP patients are about 50% of CIDP, just like the patient I showed you. It tends to be symmetrical proximal and distal weakness with hypo or areflexia and more large fiber sensory loss because it's affecting the more heavily myelinated sensory fibers. It makes sense. So they can have some sensory ataxia as a component as well. And then the variants or atypical forms of CIDP, they are atypical because it affects a certain part of the body, right? So, or a certain type of nerve fiber preferentially. So we have a distal variant, we have a focal and multifocal variant, we have sensory predominant, motor predominant, and we'll go through all these in detail. And then I left autoimmune nodopathies, including anti-MAG neuropathy at all in this discussion. I'll go through that in a little bit. But if it's distal CIDP and they do not have anti-MAGs, then we would consider it CIDP still. Autoimmune nodopathies have come out on their own. All right, so to go through some of the variants, sensory CIDP is considered the most common variant of CIDP, affecting up to 35% of all CIDP patients, depending on what paper you look at. So patients will have, as you might imagine, a lot of sensory complaints. They'll have distal paresthesias, hyperesthesias, and proprioceptive ataxia, and they might go on to develop weakness. So the motor involvement is often more prevalent on the electrodiagnostic studies. So this is an older study now from Muscle and Nerve, but 22 patients with sensory CIDP, and they had unusual features, right? That really should clue you in that this could be the diagnosis. Unusual features: early gait ataxia, generalized areflexia, some cranial nerve involvement, upper limb onset. So all of those would maybe kind of raise your alert that this could be an inflammatory autoimmune condition. And then sometimes, because sensory CIDP preferentially affecting the sensory nerve fibers might be harder to diagnose. So you might need to lean on some of these other supportive types of diagnostic studies, such as somatosensory evoked potentials or spinal fluid analysis to help make the diagnosis. With that, I'm going to go on a very brief tangent. So I already told you that CISP, or chronic immune sensory polyradiculopathy, is no longer considered a subset of sensory CIDP since the reclassification in 2021. But this is a condition not to be missed. And honestly, I feel like a lot of these patients probably end up being labeled as having a functional neurological disorder. They come into clinic, they're horribly ataxic, complaining of sensory symptoms, they have normal strength, and they have normal nerve conduction studies, right? So you can imagine that's a situation in which a lot of those patients are going to get dismissed. But if you look, they should have abnormal somatosensory evoked potentials, elevated spinal fluid protein, and then the MRIs can demonstrate enlarged and contrast-enhancing lumbar roots. And so this is really focal demyelination at the sensory root level. So you're missing it. It's preganglionic. You're missing it on routine nerve conduction studies. And that's why these other studies are helpful in making the diagnosis. And the Mayo Group originally described this. And these patients do tend to respond to IVIG and corticosteroids. So no longer CIDP. And so this was actually published back in 2021, a newer diagnostic criteria for CISP. And essentially, it's exactly what I just told you. So these patients need to have sensory symptoms without weakness, normal nerve conduction studies, and 2 out of the following 3: normal somatosensory evoked potentials, abnormal MRI, or elevated CSF protein with normal cell count. Now, pivoting over to the motor side, motor CIDP. So this might make up to about 10% of CIDP patients. And they can also, similar to the sensory side, have subclinical sensory involvement or evidence of it on nerve connection studies. So now when there is sensory involvement on nerve connection studies, we are calling it motor predominant CIDP. So some patients with motor CIDP will have an asymmetrical deficit that is more reminiscent of multifocal motor neuropathy. And then there are also some reports that patients worsen with exposure to IV corticosteroids, which is reminiscent of multifocal motor neuropathy, in which we never treat them with corticosteroids because of potential worsening. And so this study from back in 2019 looked at these motor CIDP patients. And again, this predates the reclassification in 2021, but they divided their patients as a retrospective study into pure motor CIDP when there is no abnormality on sensory connection studies, and then those with motor predominant where there was at least two lower sensory responses. And out of 700 CIDP patients they had in their database, 2% or 17 were included. And the importance here is that 40% of the motor predominant patients did with time develop sensory symptoms, right? And remember, those were the ones that had sensory changes on the nerve connection studies. These patients were median age of onset around 48, and then more men than women. And they had frequent and multifocal conduction block. And then they responded very well to IVIG, not surprisingly. And half of the pure motor patients actually responded to corticosteroids. So as I mentioned on the previous slide, some of those patients might worsen with corticosteroids, but that's not universally the case. And so when I think about this data, I really think about motor CIDP and multifocal motor neuropathy perhaps existing on a continuum. They definitely share several features. Pure motor, often younger age at onset, beautiful response to IVIG. They might have anti-ganglioside antibodies and multiple motor conduction blocks. But how would we think about them differently? So in motor CIDP, it should cause diffuse weakness instead of picking off individual peripheral motor nerves. And then these electrophysiological changes are also diffuse. And then again, as I said, possibly they could improve on steroids, whereas we don't use them in MMN. So focal CIDP, I think, is a really challenging diagnosis to make. So by definition, it's involvement of a brachial or lumbosacral plexus or one or more peripheral nerves in an upper limb or a lower limb. It's focal. And it is about 1% in a large retrospective CIDP cohort. So these patients are really hard to diagnose. And so I have only had probably about 4 in my career so far. So there are several series of these patients that have been described in the literature, and there's some reports of them, improving on steroids and IVIG, but I also find that they can be kind of challenging to treat. There are also some reports of those who have motor predominant presentations actually worsening with corticosteroids, again, reminiscent to the MMN patients. So this paper that was published back in 2021 on focal CIDP, again, kind of defined it as brachial or lumbosacral plexus involvement or one or more peripheral nerves in an upper or lower extremity. And they looked at 30 focal CIDP patients. So it's actually a really big series for such a rare condition. And of those 30 patients, 18 had plexus neuropathies, 7 had sensory motor or sensory peripheral nerve involvement, and 5 were pure motor. And so the key point here, these are key points. The focal plexus neuropathies often needed imaging to make the diagnosis. I feel like that's always being done, or somatosensory evoked potentials to make the diagnosis. You can imagine if it's such a proximal lesion, you might miss the conduction block on routine nerve connection studies, right, to make that diagnosis of CIDP. And then also for those who had involvement of the plexus, over at least 2 years, it tends to stay in the plexus for 94% of the time in this series. So that's a good thing to know in order to counsel your patients. And then also, very importantly, sensory motor, pure motor variants would often transition to multifocal CIDP or would be considered more multifocal motor neuropathy. So those would evolve. So multifocal CIDP is exactly as the name says. It's chronic, it's asymmetrical, it affects sensory and motor fibers, and it's of course demyelinating. It also goes by the older term Lewis-Sumner syndrome, or my favorite, MAD-SAM, which is multifocal acquired demyelinating sensory and motor neuropathy. And in the reclassification, we are just calling it multifocal CIDP right now. So it affects about 15% of patients. 2 can relapse, remit, or be chronically progressive, and tends to affect the upper extremities before the lower extremities. Now, very importantly, about a quarter of these patients can have cranial nerve involvement. Spinal fluid analysis is not as helpful in this condition, as the protein might be slightly elevated or even normal. And then also importantly, and we do counsel our patients on this, about half of the time they will evolve to a more typical CIDP picture. And there's some literature out there that maybe upper extremity predominant patients will respond better to corticosteroids and lower extremity might respond better to IVIG. And there's also, not unlike the other variants I've mentioned, some reports of deterioration following corticosteroid treatment. Now, distal CIDP gets a little bit murky because we've been reclassifying. And so it's distal acquired demyelinating symmetric neuropathy is the older term, or DADS. And these are patients, older men typically, that present with distal symmetric sensory ataxic neuropathy, right? So they really have a lot of gait ataxia, and it's gradually progressive. And these patients certainly have less disability than typical CIDP. And electrophysiologically, the characteristic is these very prolonged distal motor latencies and slowing of motor conduction velocities. And then always in CIDP, you'll hear about this in a moment, we will get serum protein electrophoresis, immunofixation, and look for evidence of monoclonal gammopathy. But a lot of these distal patients will have an IgM monoclonal gammopathy. And if they do, we also check anti-MAG antibodies, or myelin-associated glycoprotein antibodies. So if they have, as I mentioned at the very beginning of this talk, if they have anti-MAG antibodies, we no longer classify them as distal CIDP. They move out of that umbrella and they stand by themselves. So 2/3 of DADS patients, or distal CIDP patients, will have an IgM monoclonal gammopathy, and of those, 1/2 will have anti-MAG antibodies. And also the bottom line is, if you have anti-MAG antibodies, especially, the treatment response is disappointing. In the literature for those patients, they tend not to respond to IVIG or corticosteroids. There's probably about a 30 to 50% response rate to rituximab, 30 to 50%. And then if they don't have anti-MAG antibodies, absolutely we try to treat them with standard CIDP treatment, including corticosteroids or IVIG. All right, now back to another tangent. I would be remiss if I didn't briefly cover the autoimmune nodopathies, or notoperinodopathies, or seropositive CIDP, it used to be called, just because this really is another acquired demyelinating polyneuropathy that we used to consider under that CIDP umbrella. Frankly, can look very, very similar to CIDP. So, looking back, there is a small subset of patients that would meet demyelinating CIDP criteria for sure, either off the FNS PNS criteria from 2010 or the updated 2021 EAN PNS criteria, that have these autoantibodies that are directed either to the perinodal complex. So this is neurofascin 155, contactin 1, contactin associated protein 1, and I'll show you a graphic here in a moment, or to nodal neurofascin 14186. And these tend to be IgG4 antibodies. And these are now, like I've said now several times, considered autoimmune nodopathies and no longer seropositive CIDP. So this is a figure that you'll see in a lot of talks on CIDP. I think we keep just using this one over and over again. But you see in the perinodal region, you've got NF155, contactin 1, and Casper 1 that are the targets of these antibodies, and then also NF186, 140 in the nodal region. And I could give a several-hour lecture just on these diseases. They're very interesting. But this is a nice summary slide, summary figure that was published in 2023 that looks at some of the defining characteristics associated with some of these specific autoantibodies, but then really what do these have in common? They often are distal predominant motor weakness. They often have profound sensory ataxia. Key, poor response to IVIG. Okay, so if there is a patient that looks very demyelinating on nerve conduction studies, who's declining rapidly, who's been getting IVIG and still doing worse, I mean, you would certainly stop and think that this could be an autoimmune nodopathy. And I'll show you a slide in a little bit, but they have really strongly demyelinating features on their nerve conduction studies. And as I mentioned, the autoantibodies that tend to drive these unusual phenotypes are IgG4. Now, there are some IgG1 and IgG3 autoantibodies that can be associated with these, NF155, connectin-1, et cetera, but they tend to follow a more typical CIDP presentation and treatment response kind of presentation. All right. So in terms of evaluation and diagnostic criteria, as you've sort of caught on, we have pivoted and switched to the 2021 criteria. So bottom line is you need the clinical picture to be appropriate to make a diagnosis of CIDP, and then you need the electrodiagnostic studies to support that diagnosis. And so as I mentioned at the very beginning, you need numbness and weakness that evolves over at least 2 months, and then it can be progressive or relapsing. We expect you to have absent or reduced reflexes, as well as the core clinical features. And there are over 15 different sets of diagnostic criteria. And why do we think we keep reinventing the wheel here? We don't have a great diagnostic biomarker. And so still today in 2024, almost 2025, it's clinical presentation plus supportive electrodiagnostic features. So within that 2021 EAN PNS criteria, there are the clinical criteria and the electrodiagnostic criteria. This is a terrible slide. The print is way too small, and I would never expect you to read off of this, but this is basically showing you that this exists and is essentially what I have just taught you. So that typical CIDP, has this very specific presentation. It's going to be more proximal and distal and symmetric and progressive or relapsing over that certain time period with reduced reflexes, and then the variants and how they're classified as I've just shown to you. All right. And then one way to think about it, does CIDP, the patient you have in your office, do they meet the clinical criteria? Yes. Okay. Do they meet the electrodiagnostic criteria? Yes. Well, that makes it easy then, right? Then they have CIDP. Well, what if they meet the possible electrodiagnostic criteria? And so I'll show you the electrodiagnostic criteria in just a moment. But basically what we need with this updated criteria is we need acquired demyelinating changes in at least 2 motor nerves and abnormalities in 2 sensory nerves to be sort of a definite CIDP picture electrodiagnostically. But what if you only have 1 motor nerve affected with acquired demyelinating features and 2 sensory? Then you're in that possible kind of gray zone. And that's when we start to rely on our supportive criteria like spinal fluid analysis and imaging to help make the diagnosis of CIDP. Again, the sensitivity and specificity of the updated criteria. So the EAN PNS criteria, the sensitivity for possible CIDP is 83% and 74% for CIDP itself versus the EFNS PNS criteria. So we've actually dropped the sensitivity a little bit with this updated criteria, but the trade-off is the specificity is much greater. So for possible CIDP, it's 88%. For CIDP itself, 98%. And that's up from 68% and 84% respectively. So that we have a more specific test now. All right. I just wanted to include a slide or two on diagnostic delay and kind of misdiagnosis. This is a real problem. These patients can go around and see a number of different providers before they get to someone and get a diagnosis of CIDP. And so the average time from symptom onset to diagnosis is anywhere from 12 to 40 months. This is a huge problem. So if you have something that starts off life as an acquired demyelinating neuropathy, and then you get a lot of secondary axonal degeneration, that is where you get permanent disability, right? You might not be able to ever grow those axons back no matter how much treatment we give the patient. And so we really need to focus on rapid diagnosis and early initiation of treatment to try and prevent that permanent disability from occurring. So the flip side is there are so many patients that are misdiagnosed as CIDP. I'm sure just like Dr. Edmondson, on a weekly basis, we are actually undiagnosing patients with CIDP. And so we think the misdiagnosis rate is 50% or higher. And then what's the problem here? These patients are getting treatment that is not needed and potentially harmful for months to years. I just pulled someone off of 3 years of IVIG for CIDP when in reality had a cervical radiculopathy. So what are some conditions that are frequently confused with CIDP? Certainly the polyneuropathy associated with POEMS syndrome, which again looks very demyelinating. Familial amyloid polyneuropathy has been reported to be confused with CIDP. It can be a little bit slowing. Even CMT or Charcot-Marie-Tooth disease, the demyelinating form of it, sometimes patients get mislabeled as CIDP, and in reality, it's a genetic neuropathy. This recent publication from the European Journal of Neurology in 2021 just shows you, and again, I'm not going to read this all out to you, but all the different types of diagnoses that patients ended up having that were initially diagnosed with CIDP, everything from paraneoplastic syndromes to vitamin deficiencies, again, some amyloidosis and different types of monoclonal gammopathy-associated neuropathies or hematological malignancy-associated neuropathy. So we always have to be considering and reconsidering the diagnosis. So as I've already highlighted, nerve connection studies are really the key to making the diagnosis in those patients that meet the clinical profile. And just to try and keep it really simple here, and I know that probably most of the people on this talk with me right now don't do EMG for a living. The key is we're trying to find nerve connection study abnormalities that are consistent with acquired demyelination. So that just basically results in slowing down of these nerve responses. So that would be in the form of prolonged distal motor latencies, slowed motor conduction velocity, as well as some other features called conduction block and temporal dispersion, which are hallmarks of acquired demyelination and differentiate it from inherited demyelinating neuropathies. We see slowing resulting in prolonged or absent F-wave responses. And then we also see on the sensory side, absent or reduced responses. So as I already alluded to a few slides ago, the EAN-PNS criteria has 2 different levels of electrodiagnostic certainty, CIDP or possible CIDP. And the possible is when you have the one motor nerve with the demyelinating features, and CIDP is 2 or more. Now, and also the big update compared to the 2010 criteria is now we need abnormalities on the sensory studies to make a diagnosis of CIDP. So you need 2 sensory nerves that are abnormal. And again, this is copy and pasted right out of that this is actually from an update from Muscle and Nerve on 2022, but it's from the EAN-PNS criteria, looking at the motor and sensory nerve conduction criteria. And again, I'm not going to read this to you, but just to show you that this exists and you can easily reference it. Like we print it out and like tape it to the wall in the EMG lab. So back to my patient that you remember has a typical CIDP presentation. These were his sensory nerve conduction studies. Always say you don't need to be an EMGer to know that there's something wrong here because every single sensory nerve has no response. And then just to take a quick look at the motor nerve conduction studies. So starting off here, we have kind of at the top of the screen, a right median motor nerve conduction study recording over the abductor pollicis brevis, left median recording over the abductor pollicis brevis, right ulnar recording over the ADM, and a left radial recording over the extensor indicis proprius. So with each of these motor studies, what you'll see is something called conduction block, where the proximally stimulated compound muscle action potential is lower amplitude than the distal CMAP amplitude. And then here you'll see it just with the actual waveform. So this is the distal right median to APP CMAP, you see the higher amplitude, and then with more proximal stimulation, you see a significant drop off in that amplitude. The other features you'll see are prolonged distal motor latencies, as well as really profound slowing of conduction velocities across the board here. So with my case, what I went back and did was I compared it to the diagnostic criteria, and I could check all of the boxes and give this gentleman a diagnosis of CIDP. But you don't stop there. There are a few other things you need to do. As I mentioned previously, you do need to check a serum protein electrophoresis and immunofixation. And some of these patients have monoclonal gammopathies, and if so, then I always send my patients over to hematology. You can certainly see demyelinating neuropathies associated with myeloma, for example, and so you just don't want to miss that, right? And then if ultimately it's determined that this patient has just CIDP and they happen to have a monoclonal gammopathy, then we would treat them just like any other patient with CIDP that does not have a monoclonal gammopathy. But if they have an IgA and IgG paraprotein, especially with a lambda light chain, you want to start thinking of these other kind of zebras, if you will, like amyloidosis, POEMs, cryoglobulinemic vasculitis, and lymphomatosis. You just don't want to miss one of these mimics. And so, again, as mentioned previously, if they have an IgM, it doesn't hurt to always get an anti-MAG antibody, especially in the distal predominant presentations. And then I always send to hematology, as I said. So antibody testing. So I've been asked this a lot recently, as I'm sure Dr. Edmondson has, in all of your CIDP patients, are you getting antibodies? I would say I definitely am for the new ones that are coming in the door that haven't started treatment or that are new to me, and I'm not really sure how they're going to respond to treatment yet. It doesn't hurt. They're commercially available now. It would influence the way that you treat the patient because IVIG does not tend to work in these patients, and we would certainly classify them a little bit differently. Genetic testing, we certainly don't do that routinely, but if someone fails to respond to CIDP treatment, again, think of the mimics. Could this actually be Charcot-Marie-Tooth instead? So spinal fluid analysis. So classically, as everyone learned in medical school and residency, we're looking for albuminocytologic dissociation, right? So high protein because of the sloughing off of the protein off those inflamed nerve roots into spinal fluid with a normal cell count. And so I do not routinely get spinal fluid on patients unless I need to make a diagnosis or unless there are unusual features like a ton of pain, a lot of weight loss, things like that. And so, but if you were to do it, 77 to 95% of patients with CIDP will have elevated protein, really high, 3/4 of patients with sensory CIDP, and then also the minority of patients with multifocal CIDP will have high protein, so only 34%. As I said, it can be used as a supportive criteria, supportive diagnostic test to help in those cases where a patient meets possible electrodiagnostic criteria. And again, if you're suspecting anything else going on, like an infection or malignancy, can be helpful. Now, this is really one of the pitfalls in overdiagnosis, though I must say that some patients with slightly elevated spinal fluid protein and a little bit of slowing on nerve conduction size might get labeled as CIDP. So diabetes can bump your protein level, age, spondylosis. So just be careful, especially if the spinal fluid protein level is only in that kind of just barely elevated category of 45 to 60 mg per deciliter. So be very cautious then. And then imaging, I find it most helpful in the cases of patients with the focal multifocal CIDP, and then also can be supportive criteria as well in the patients that are kind of in that gray zone. It can help exclude spinal cord pathology. And as mentioned, you would expect to see an enlargement and enhancement of the nerves. But the issues are MRI is costly. Frankly, at VCU, we don't have great neuroradiologists to read nerve MRI. So sometimes I feel like it's not a great study. Some institutions don't have neuromuscular ultrasound to bail you out. So you just really have to think about your institution and whether or not this is going to be a high yield study for you. But as mentioned, MRI, if we do it, we're looking for those hypertrophied, contrast enhancing roots, plexus, cauda equina. So some studies have demonstrated that you can have an abnormality in the brachial plexus in CIDP, not just focal CIDP, in 44 to 82% of patients. And again, ultrasound can also show nerve enlargement focally. And then the last tangent before we go on to treatment. So these autoimmune nodopathy patients, this paper now I think is 2020, they are profoundly demyelinating looking. And so this paper looked at 13 nerfacin 155 patients, 9 contactin 1 patients, and compared it to 40 seronegative patients. And they all, and again, this is 2020, met the EFNS, PNS electrodiagnostic criteria for definite CIDP. That's how demyelinating they were. And then, in fact, if the median nerve conduction, motor conduction velocity was less than 24 meters per second, ulnar less than 26, or ulnar motor distal latency greater than 7.4, this was predictive of positive antibodies with a sensitivity of 59% and specificity of 93%. So really, if you see something profoundly demyelinating, always think that it could be one of these autoimmune nodopathies. And lastly, nerve biopsy. We really don't do this anymore in CIDP. There is absolutely no indication unless you're worried that there's something else going on, if they're not responding to treatment. And so what would we expect to see? We see thinly myelinated axons. We see perivascular macrophage collections and onion bulb formation from the demyelination remyelination. And then it can help rule out infiltrative processes, sarcoid, amyloid, nerve sheath tumors. But again, just in straightforward CIDP, the diagnostic yield might be pretty low. And then, of course, there's some morbidity associated with it because you're taking a nerve out of the patient. So sural nerve biopsy, if we were to do it, should demonstrate demyelination, remyelination in about 2/3. We rarely see inflammatory infiltrate on nerve biopsy in CIDP, and as mentioned, is not needed in the most straightforward cases. So in the last few moments, we'll go through treatment. So I like to think about it as you've got a kind of de novo CIDP patient in your office or in the hospital. What are you going to treat them with first? Your choices, your corticosteroid therapies that are longer term, corticosteroids, IVIG, subcutaneous immunoglobulins, and then second line, and I put plasma exchange there. And then efgartigimod, we could sit and debate at the end kind of where we should put this in the algorithm. But right now, I would say probably nationally, it's considered second-line treatment for maintenance. So 50 to 70% of patients will respond to each therapy. And then if you switch them, an additional 50% will respond, yielding about an overall response rate of 80%. So just to go through these corticosteroids, my general impression in the United States, to be honest, is that most of us would choose IVIG as the first treatment choice for patients with CIDP because of the side effect profile with corticosteroids. But what's the data to support using corticosteroids? There's several non-controlled studies and 2 controlled studies that demonstrate the benefit of corticosteroid treatment. And so who responds to corticosteroids? Not surprisingly, as I mentioned, if it's a shorter disease duration, you have less axonal degeneration, you're going to do better with corticosteroid treatment. Slower nerve conduction stays, more demyelination, you're going to do better with corticosteroid treatment. And then female gender and younger age apparently, predicts a better response. And then corticosteroids, there's some literature out there. Maybe this is more helpful for inducing long-term remission, and we'll come back to that. So steroids have a very broad spectrum kind of mechanism of action, from suppressing T cell proliferation, downregulating pro-inflammatory cytokine production, suppressing the humoral response, resulting in decreased antibody production. Everyone on this call knows of all the terrible things that steroids can do, from elevating your blood sugar, your blood pressure, your cholesterol. You can have insomnia, mood change, glaucoma, cataracts. Your bone health is at risk, adrenal insufficiency, and so on. And then, so we need to monitor patients, right? We do annual bone density scans, we check their blood sugars, blood pressure, and we keep an eye on their weight. Now, it's just worth mentioning, I'm not going to go through this in a lot of detail, but there have been a lot of different treatment regimens that have been described for using corticosteroids in CIDP, from daily dose prednisone up to 1.5 mg per kg. Pulse dexamethasone, 40 milligrams a day times 4 days in a row monthly. Pulse methylprednisolone, for example, 500 milligrams a day times 4 days monthly, as just some examples. And then switching to IVIG, these are pooled purified, isolated IgG antibodies. And I always think this is so amazing, from 3 to 10,000 donors per batch. I always say it takes a village to make a bottle of IVIG. But the dosing is usually, the first dose is sort of the initial dosing is 2 grams per kilogram divided over 2 to 5 days. And maintenance therapy really depends on patient's response, right? So it's anywhere from 0.4 to 2 grams per kilogram every 3 to 8 weeks. And it's super important to constantly constantly adjust the dosing and the frequency to see what the patient really requires. I see so many patients referred to me that are just put on 1 gram per kilogram every 4 weeks, and that's just, fix it and forget it. And that's not what we want to be doing. And this was, IVIG was FDA approved in 2008 after the ICE trial, which I will just very briefly show you because it has a lot of historical significance. It was the largest CIDP trial ever conducted at the time. It was the first trial that actually showed and proved that IVIG worked. There were 117 patients that were enrolled, randomized to either IVIG or placebo every 3 weeks in the study, 1 gram per kilogram, and there was a crossover phase as well. And they showed that there was clinically meaningful improvement in disability in 54% of IVIG patients versus 21% of placebo. And you see in red, it was clearly statistically significant. For every 3 patients treated, 1 additional patient with clinically significant improvement on IVIG. And then the figure here is looking at the patients who had relapses. So in the blue is the placebo over time and weeks. So you see just over time, a lot of patients on placebo, up to 50% did relapse, and then many fewer on the IVIG. I just point this out too, that 50% of patients on placebo did not relapse. And that just goes to show that some of these patients can come off therapy at least for a period of time and don't need to be on chronic IVIG. All right, so mechanism of action. I feel like when the residents and medical students always ask us how IVIG works, we kind of say we're not exactly sure, which is true, but we have a sense that it does modulate the innate immune system, the acquired immune system. It interferes with binding of leukocytes on the vascular endothelium. It also binds the Fc receptors on these phagocytic cells and diminishes their potency. It actually saturates the neonatal Fc receptors on the vascular endothelium and speeds the clearance of IgG autoantibodies and hinders complement. So really a broad spectrum of different mechanisms of action. And for those of you who give a lot of IVIG, we've got to give pre-treatment. We do Benadryl, we do Tylenol. Sometimes we give a little steroid because patients can have fevers, chills, muscle aches, headache, flushing. We see occasionally nephrotoxicity. It makes your blood temporarily increase in viscosity, which could tip you over to any sort of stroke, heart attack, blood clot, DVT, PE, that sort of thing. So what do you choose then, right? So a lot of studies have shown that corticosteroids and IVIG are equivalent in short term, but some have suggested that IVIG is better in the short term, and as I already mentioned, maybe corticosteroids are more effective for long-term remission. In some studies comparing the two, higher number of patients will discontinue steroids because, frankly, the side effects are terrible. So it really begs the question, should we be doing combination therapy in these patients? And there is an ongoing trial called OPTIC looking specifically at this. Can we get benefit from both of them? Short-term efficacy and long-term remission if we combine. So more to come on that in the future. Briefly, subcutaneous immunoglobulins are available and on the market. And so FDA approved for Hizentra in 2018 for CIDP. This allows patients to self-administer immunoglobulins, as you see here, through their abdomen. And the dosing range is 0.2 to 0.4 grams per kilogram weekly. And so which do you choose? There's a little bit of signal that there are less relapses in the high dose group in the open label extension study, but we're all a little bit different in what dose we start with for that. So this came out of the PATH study, the FDA approval of Hizentra, the sub-Q IG product. This had even more patients enrolled, 172, with 57 going on placebo, 57 low dose, and 58 high dose sub-Q IG weekly for 24 weeks with an intention to treat analysis. And the results, again, 63% of patients on placebo, 39% on low dose sub-Q IG, 33 on high dose sub-Q IG had a relapse or withdrew from study. So, twice as likely to have a relapse or withdrawal on the placebo, as you see here, compared to high dose here and low dose there, okay, over time. And then finally, in the IG spectrum, we have facilitated sub-Q IG, which is FDA approved, called HyQvia. It was FDA approved at the beginning of 2024. This is using hyaluronidase as well with this immunoglobulin product. You self-administer, but the hyaluronidase increases the subcutaneous permeability to IgG to allow you to give higher concentrations of IgG at a time. So you can, in theory, dose it less frequently than sub-Q IG like Hizentra. So even maybe once a month, and it's self-administered. So this study design, this advanced CIDP trial, was just published in June 2023, and looking at patients 132 with probable or definite CIDP, based off of the old criteria, with INCAT, inflammatory neuropathy cause and treatment score criteria, which reflects their level of disability from completely none to pretty significant disability in a score of 7. They received, they went over from IVIG to placebo or this facilitated sub-QIG with a 1-to-1 randomization. And then compared to placebo, the facilitated sub-QIG patients had a 21.8% reduction in relapse rate, which resulted in its FDA approval. Briefly, plasma exchange removes normal antibodies, abnormal antibodies, pathogenic antibodies, immune complexes, and complement proteins. We will use this often, I would not say often, but not infrequently, in CIDP patients who are hospitalized. It tends to be initially 5 exchanges every other day. And then, the complicating factors here are require central venous access. There are some facilities that would do it through peripherals, but for us, we have to do it through central venous catheter access. And it's considered off-label technically for CIDP. There are 2 very old studies that demonstrated the benefit of plasma exchange, one from 96 and one from 86. And both of these were low number of subjects. Both of them had either exchange or sham exchange. And then in both studies, the treated patients had improvements if treated with plasma exchange in their neurological disability scale, motor function assessments, and nerve conduction studies. And then, as you all likely know, plasma exchange, the issues are related often to the catheter-related complications, including infection, thrombosis, pain. They can drop their blood pressures and have low calcium. And so we monitor their vitals in their labs. And then efgartigimod, which is Vyvgart Hytrulo for CIDP, which is now on the market. And so I just want to spend a moment talking about this. This is a neonatal FC receptor inhibitor. So kind of what is that? So the neonatal FC receptor protects IgGs from lysosomal degradation, and prolongs the half-life of IgGs. So if we block the neonatal FC receptor, all of a sudden we have less recycling of IgG, and that IgG is broken down the lysosomes, and we just drop those IgG subclasses, good IgG and bad IgG, okay? So if you look at this figure that Carissa Gable published in 2020, these are normal IgGs coming in, hooking up to the neonatal FC receptor. As long as they're attached, they don't get degraded. IgGs that are not attached get degraded in the lysosome. The other ones are recycled out into the bloodstream. Here is the neonatal FC receptor antagonist or inhibitor therapeutic. If that comes in and hooks up to the neonatal FC receptor, it binds with a stronger affinity than normal IgG. That leaves your other IgGs out here getting degraded, and we're recycling the drug, not the IgGs. So the ADHERE study, just briefly, because I know we're kind of running short on time, was a double-blind, placebo-controlled phase 3 trial, complicated study design. There was a stage A and a stage B. So patients who had clinically meaningful deterioration, kind of in washout, like they got worse off of their drug, off of IVIG or steroids, entered open label, got 1,000 milligrams of sub-Q efgartigimod weekly for up to 12 weeks. For those who improved during that period, they went into the stage B, where there was a withdrawal of it, and they went on to placebo or continued to get it. All right. So primary endpoint for stage A was confirmed improvement. And so that was a point or greater improvement in NCAT score or on this Rushbelt overall disability scale or grip strength after 4 injections and for 2 visits. And the primary endpoint for stage B was risk of relapse because some of those were on placebo. And time to greater 1 point adjusted NCAT score increase, so worsening. So there was a 66% treatment response in stage A, and with stage B, when it was placebo controlled, 61% risk reduction of relapse, so 27.9% relapse with efgartigimod compared to 53% with placebo, clearly statistically significant. And so this drug is on the market. It is dosed weekly. It's subcutaneous and needs a healthcare provider to administer it. Even though it goes in 30 to 90 seconds, you can have skin reactions, hypersensitivity reactions. And then given that we have very essentially no time, I want to take some questions. I'll just say for refractory CIDP, our patients, first, if you have a refractory patient, consider other diagnoses first. And then if you're still sure they have CIDP, I would say rituximab would be the next one to go to. There is some data to support that it can be helpful in refractory patients. There's also scant data on cyclophosphamide as a potential treatment. And then steroid-sparing agents like Imuran, Salsap, things like that. You could consider it, but there's really limited to no data whatsoever. And so with that, I'm just going to click through because some of these are emerging therapies that are in early trials that we won't cover. And then how do we monitor for improvement? This is outrageously important. You want to follow your patients and track how they're doing over time somewhat objectively. So that might be grip strength. You want to use quality of life instruments like the CAPRI. You want to use disability scores like the NCAT and the IRODS. And then, just so we monitor those over time. And so hopefully we've gotten through all these objectives very quickly in the last hour, and I appreciate your attention. And I'm happy to take any questions in the last moment or two.
Thank you so much, Dr. Gwathmey. That's a really big topic, and it's always awesome to hear you talk on it. We have a couple of questions. The first is coming from Mike Elliott, and he's wondering how one would distinguish Parsonage-Turner from focal CIDP affecting the brachial plexus, or if there are particular ways you might go about doing that.
Yeah, that's a fantastic question. Hi, Mike. So I would say clinically, it's really how you differentiate it, right? So imaging wise, I think they can look extremely similar in the acute setting with Parsonage-Turner versus focal CIDP. But of course, Parsonage-Turner is usually like significant pain that's relatively acute to subacute, and then that's followed by weakness and atrophy and has kind of less sensory involvement in the background. So, I mean, I think clinically they look quite different. We don't tend to see CIDP causing that much pain, and definitely don't tend to see it focally that acutely. Electrically, it can be sort of challenging. So they both can look like plexopathies. And like I said, because of the location of the plexi, sometimes you can't catch those conduction blocks and temporal dispersion because it's so proximal. And so you might miss it electrically. So if you can see features of demyelination, obviously that goes towards focal CIDP and away from Parsonage-Turner. But it's really the clinical history I think is key there. Great question.
Great, thank you. And then one more question is in terms of sending those neurofast and contactin antibodies, you've mentioned that you're doing that for most new CIDP diagnoses who you're seeing. And I'm wondering where you're doing that. Are you doing it through Mayo? Are you doing it through WashU? Do you have thoughts on the Casper-1 antibody?
Yeah, so for years sent it to WashU, like most of us did, I think, for the last 6 years or so. And then, it's commercially available through Mayo now. So I'm, because of contracting, we send to Mayo at VCU. And then in terms of Casper-1, no, I don't have specific thoughts about that one compared to the others.
Right.
You mean in terms of okay.
If it's useful.
Yeah.
Thank you. Thank you so much,
Dr.
Gwathmey, for that awesome presentation. I also want to just take a quick minute to thank the sponsor of today's presentation, which is UCB. and really appreciate you, Dr. Gwathmey, taking the time to come and review all of this with us. We're getting some chirps in the chat, so that it was a great presentation, complex topic,
Thank
and really
you.
appreciating you being here.
Yes, I appreciate the invitation again and everyone's attention and engagement. So thank you for that. And happy holidays.
All right, happy holidays. Take care.
All right, bye.
Bye.
Well, I haven't been up here for several weeks, so my sponsor did. Yeah, great. Yeah, thank you for sponsoring. I was gonna call you about next week. Okay, yeah. Yeah. Are you gonna handle that? Yes. Okay. What she usually does is emails me the forms. Like there was 12, one for every month. Yes. And then I just fill it out and send it back to her. So I can't remember. But it doesn't. Okay, yeah. Yeah, I'll check in with Lori. Yeah. And then I still need to email Charlie and Michael about the epilepsy ones. Oh, yes. Because they'll choose to do probably pediatric neurology and I just like to do the neuro-ophthalmology and then the neuromuscular. Okay, yeah. Thank you. Yeah. Gosh, before COVID, standing room only. Oh yeah, I would stand in the back. Everybody was here. I could put a table in there.